So a little bit more in essence about the work that we are doing in general in my team. So Daniel already mentioned this very briefly, but in essence, from an application point of view, so we are using and developing AI and machine learning models to address different major topics in pharmaceutical or medical research. So one is how do you, in a rationalized manner, hopefully a rationalized manner, identify targets at first place, therapeutic targets. Second, then actually, if you have at some point a medication, so whom should you prescribe it? Yeah? So basically all facets of precision medicine. And then later on, of course, the question is, how can you show that such a medication really works? So that has to be done usually via trials. So how can AI and machine learning actually support the design of clinical trials? Yeah? So these are the three major areas. And yeah, of course, this has strong overlap with work that's done in industry and specifically, of course, in pharma industry and biotech, but of course also in the public health sector. And yeah, from a methodological side, so Daniel also pointed out there are a few things. So yeah, we are doing a lot with hybrid AI / knowledge infusion. So for example, graph neural networks play an important role specifically in this area of target prioritization. Also scientific, so-called scientific or gray box machine learning, specifically in the area of support of clinical trials. And then, of course, also various aspects of time series play an important role, since at the end of the day, any disease has a time dimension, which must not be forgotten. And we use and develop the different approaches. Some of them I will show you. And yeah, of course, there's not the one and only data source in medicine which is relevant, but I think the art is more how to integrate and combine data across different medical and biological scales, such that at the end of the day, a benefit can be achieved for a model. And yeah, for that purpose, obviously, different approaches are necessary. So from a data point of view, so we are also covering a certain area, a certain range. So obviously nowadays in medicine, data is vast. So there are various types of data modalities that are nowadays used, even up to social media. But we mainly focus in my team on longitudinal clinical study data, real-world data also, so data that's really coming from medical routine, which then comprises different aspects. So like, for example, electronic health records, or you will see here also an example with device data, and partially also omics. So also this is not the main focus as such. So one of our areas of interest here in my team from a disease, from an application, medical application point of view, is neurodegenerative diseases. And let me just introduce this a little bit by showing you the underlying issues, actually, why we do that. So in essence, one of the things or figures that you can see here on the right-hand side is a projection of the dementia cases in millions, which have been published here by the Alzheimer's Disease International Society in the World Alzheimer's Report already in 2015, which already show the general problem, namely that neurodegenerative diseases at the moment are strongly increasing in prevalence. And this holds not only true for Alzheimer's disease, but also for other neurodegenerative diseases. So for example, Parkinson's. And of course, one of the reasons is simply age. Yeah? So we are in many countries in aging society. Yeah? So which, by the way, then, of course, since you are here working at the DKFC, yeah? So also includes cancer here as a risk factor. And what is now also a problem here from a more global point of view is what you see here also is that low and middle income countries are actually over proportionally affected. So at the same time, the issue is that there are limited therapeutic options. Some pathologies indeed start decades before there are first symptoms. And the diagnosis as such is often very difficult and often comes simply too late. And it can only be done usually in very specialized medical centers, so by a neurologist typically. The underlying disease mechanisms from a biological point of view are usually not fully understood. So there's far less understanding than, for example, in the cancer field. So how biologically, for example, Parkinson's disease or Alzheimer's disease actually develops. And also these mechanisms may differ actually from patient to patient, the relevant driving mechanisms. And there's also a very high heterogeneity actually of disease symptoms that these diseases display. So for example, in Parkinson's disease. And this comes along with a number of challenges. So for example, to develop innovative disease-modifying drugs. Yeah? So most of these diseases, as said, have only very limited therapeutic options, and mostly these therapeutic options just address symptoms rather than they are really disease-modifying. And it's actually also very difficult to adequately manage diseases, specifically in more advanced stages. So, so now let me move on. I have here my... Good. Yeah, so obviously the question then arises, so what could be done? Yeah, so of course, one thought is we simply need approaches so that help us to earlier diagnose diseases. Yeah, so for example, we want to make sure so that we identify patients already in a relatively prodromal stage, and or even are able to identify risk factors so that may later on then develop to the development of disease symptoms. So this is in essence the question of earlier diagnosis. Second, we need, I think in the future, also approaches that help us to assess a certain molecular subtype of disease, such that we are at some point able to develop drugs targeted towards specific subtypes. Third, prognosis is an important aspect. So prognosis in neurodegenerative diseases is something far more complicated, as you will see, opposed to cancer, where in cancer mostly prognosis means survival, maybe progression-free survival. Yeah? The neurodegenerative diseases, this is far more complex. Yeah? So, and the question is here really, how can we assess an individual's speed of symptom worsening over time? Yeah? And that could, for example, then have also effects on clinical trial design. A fourth aspect, which is at the moment, given the limited therapeutic options, at least not for neurodegenerative diseases, the top priority is to predict really therapy response and or at least monitor the response to specific treatments. And last but not least, of course, there's the idea to objectively simply monitor symptoms. So symptoms in neurodegenerative diseases can be very heterogeneous, as I have said. Yeah? So, and the question, of course, arises. Yeah? So, for example, if people begin to show certain ways of cognitive impairment, if people, for example, show certain motor symptoms, etc., over time. So is there a way how to monitor this in a objective manner, really, rather than relying on simply what patients report about themselves? So for example, last night I didn't sleep so well or so. Yeah, so this is highly subjective. So, and of course, last but not least, I think in the future we need approaches that help really to evaluate in the real world and not only in trials the effectiveness and safety then of hopefully at some point existing disease-modifying drugs, and of course other non-pharmaceutical interventions, for example changes of lifestyle, so for example stop of smoking, etc. So in principle, from my team's point of view, we have worked on all of these different aspects in various contexts. And of course, the time doesn't permit to talk to all of that here, so that would, I guess, be a bit too long here. But what I want to do in the following time here is at least to highlight here two of these areas and show you there are some examples of work that they have been doing. At the end of the day, so why are we doing this, right? So it's actually about data-driven decision support, right? So the idea is that at the end of the day, with the help of models, for example, for earlier diagnosis, one is able to drive certain medically relevant decisions in the future, hopefully better and more objective than done today. So let me dive a little bit into a concrete example here. So this is actually some early work that we did here, so 6-7 years ago. So this is where we started really here with this risk modeling question. And the question that we asked ourselves at this point was, is it actually possible at all to predict for a person, so that is at a given stage, at a given point in time, actually not demented, but may have maybe only a certain mild subjective cognitive impairments. Yeah? So is it actually possible to predict the time-dependent risk of such a person to develop a full dementia in the future? So it's a time-to-event model. And we started doing that by looking into this field, in the Alzheimer's field, actually referential cohort study called ADNI. So this is a multimodal data set which comprises here very different types of data. So there was, of course, a lot of question which features to extract then from these data, specifically also from genetic variants. I will not go into that. And well, then, of course, we tested here different machine learning approaches for the actual time to event prediction, went into interpretation of models. Also at that time, explainability was already a point. Yeah, so, and that included different things. So from feature importances, at that time, SHAP was not there yet, up also to Bayesian networks to disentangle relationships between most relevant predictors. And that actually worked out relatively nicely. So we achieved here a C-index of about 86%. So the C-index is a generalization of the area under our C-curve for time-to-event models. But of course, the question was then, okay, this is done in one cohort. So how would such a model actually generalize if we would actually test it in an external cohort? Yeah? And we were able at this time to achieve or to get access to a different Alzheimer's cohort then, which is called at Neuromed, and which that was the good luck, actually largely overlapped in terms of the assessed data modalities with ADNI, such that we could harmonize both data sets together. There was a huge amount of work, as you can imagine. And then we're able to really externally test a model. Our model here trained on ADNI and then externally tested, which then led to a lower C-index of 81.5%. Okay, so this is, we could say, okay, still okay, it's nice. So we lost a few percentages, but the model was still kind of working fine. Nonetheless, I mean, we ask ourselves, so how can it actually be so that we lost this prediction performance, right? So what could be the driving reasons behind? Yeah? And in essence, what we did then at this time is to investigate a bit more simply from a statistical point of view, what might differ actually between these two cohorts here at Neuromed and ADNI. In essence, it turned out so that there were indeed quite statistically significant differences, for example, in the composition of sex here, and also in the education level, which is, of course, a important predictor here for the dementia risk, as well as indeed also in the allele of a very important gene here, ApoE4. So this is a epsilon 4 allele in this particular gene here is one of the major risk factors for Alzheimer's disease from a genetic point of view. And therefore, of course, this was a quite relevant finding here, so that indeed here significant differences were found. So now, of course, looking from the other way around, right? So when you build machine learning models, yeah, so the assumption that you always make is that all of the training samples are sampled IID, right? So independently and identically distributed. So if I find such significant differences, right, so between the training and external validation cohorts, so obviously this means so that this basic IID assumption behind the model is obviously violated, right? So which itself then leads to the question, so is it actually in some sense able to adjust for that? Or if at least can we identify patients or a subset of patients which which are comparable in the external validation cohorts to those in the original training cohort, such that indeed there the IID assumption would not be violated. Yeah? And what we tried at this point, or looked into this at this point, was an approach which is actually coming from epidemiology, classical epidemiology. So this is called propensity score matching. So propensity score matching actually means, so in practice, so that you build a model, a very simple, typically logistic regression model, which in essence tries to explain the membership, in this case to a cohort, by certain factors that are in essence confounders, if you want. Yeah? So this entire approach was originally developed from epidemiology with the idea in mind to emulate trials. Yeah? So there you have, for example, the exposure instead of cohort, or yeah, so for example, treatment or not treatment at this point. Yeah. Okay, so here we have in essence now the logit of the cohort described in essence then by these factors, which obviously demonstrate significant differences between both cohorts on one hand, but of course have also at the same time, so therefore the definition of the statistical confounder are met on the outcome to be predicted. Yeah? So, and this quantity on the left-hand side of this logistic regression is called the propensity score. Yeah? So what can you now do with it is you, for any given patient in the ADNI, in the original training cohort X, you can accept a patient Y in the external test cohort, a NeuroMed, as a matching partner, as we say, if their propensity score differ by at most a certain fraction of standard deviations of the propensity score. So this is also illustrated here on the right-hand side here with this figure here, right? So you look in essence for each of the individual patients in ADNI, right? So and then in essence you have for each of them a certain propensity score through this fitting of this logistic regression model. You have the same for each of the NeuroMed patients, and then you have in essence a certain range here, right? So which is this shaded area in which you accept a patient in the other cohort at NeuroMed as a matching partner for one of the patients in the ADNI cohort. And in case that you have multiple matching partners within a certain, as we say, caliper range, yeah, so then you select just one randomly. And if there's no matching partner, then you discard. So you can, of course, play around with this caliper range here. So I will not go into the details of that, right? So, but here for the following, we choose a caliper of 1 in essence. So now what's interesting here is that in essence, if we do that, yeah, so and therefore select a certain subset of patients from at NeuroMed, so then what happens is that instead of this red line, so this was our previous of our previous external validation performance in terms of the C index, you get what is now shown here in the box plot above. And the box plot is generated because this has been calculated over multiple matchings. Yeah? So because it's in principle a random process. And the dashed line is the original performance in ADNI. So in essence, we lift our prediction performance now for these subjects more or less to comparable range to what has been observed in ADNI. Same thing here, what you can see on the right-hand side. So this demonstrates the area of the under the ROC curve over time. So the time-dependent AUC, so which is a different way of how to demonstrate the prediction or discrimination performance of a time-to-event model. And there also you see that post propensity score matching, in essence here, prediction performance is significantly lifted compared to before, right? So what does it actually now mean? So in essence, it means that the generalizability of machine learning models is really heavily impacted by the representative of patients in the training cohort, right? So which is indeed typically not independent and identically distributed, yeah? So in essence, therefore, this means so that any external validation is indispensable to identify potential biases. Yeah? So in essence, you can think about these different studies that you have here compared or looked into from a visual point of view as kind of islands in an ocean, right? So in essence, this is, for example, ADNI, this is a Neuromed, right? And however, what we do, and each of them are kind of, yeah, separate up to some extent here, but maybe there are also areas where they overlap. Yeah, so this is the areas which we identified by this propensity score matching, yeah, or where they are connected. Yeah, so this is how you may think about this. But for sure, the situation and this is very typical. It's not only the case in Alzheimer's disease, yeah, but you will find this more or less in any disease here. The situation is really so that there is a certain bias in each of these studies introduced by selection of patients initially, right? So meaning indeed so that any model that you train on the data that you originally have may not generalize automatically to the overall disease population. Yeah? And therefore, to quantify such a bias, so you need this external validation. What is, of course, not a solution, yeah. So if you have now these different islands, just to pool everything together, yeah. So then, because such a model, if trained naively, would just be dominated then obviously by the larger cohort. Yeah? So this is not what you want. Yeah? Of course, what you can do is so-called domain adaptation. Yeah? So this is a technique that's very much used in imaging, medical imaging. So where the idea is to train then a model on cohort A to data from, and then adapt it later on to data from B. So this can be a solution. And of course, in federated learning, so decentralized machine learning, similar problems arise. Yeah? So, but there, in essence, this problem is mitigated by the fact that you have at the end of the day, a model that is decentralizedly trained, right? So where you have an aggregation step of the gradients from different submodels. Good. So now actually going back a bit to this overall problem, which we try to address in the beginning, right? So risks prediction or risk stratification, yeah? So what we have to ask ourselves here at this point is at which stage in the patient's trajectory would such a model actually potentially be applicable at all, right? So how and where should this ever be used? Yeah? And there, when we think about this, we have to see so that initially, of course, a patient is simply at home, right? So, and not at the doctor. And at this stage, at home, maybe a patient initially finds out or has the feeling that there are certain subjective impairments, cognitive impairments, certain tasks that you begin maybe to forget more things, or so that is something that you may personally just feel, right? And then eventually you at some point visit a doctor, right? So, but this doctor is also initially not a specialist, who can, for example, take an MRI or PET scan or whatever. But usually the first contact as a physician for you is the GP, a general practitioner. And a general practitioner is not able to diagnose Alzheimer's disease or of course, also usually not cancer. Yeah? But the general practitioner may just say, okay, there's something not okay, and therefore I refer this patient then later on to a specialist who can do then all types of fancy diagnostics. Yeah? So in essence, this entire idea here of a patient trajectory, right? So is something that is also the basis now of a new project, which we have started last year, a very big project with actually half funded also by industry here, called Predicto. And the other half actually is funded by the European Union here, so within the Innovative Health Initiative. And here, really, the idea is to go a step further than what I just said before and come up with a platform, really, a platform that allows, at the end of the day, to assist, on one hand, patients themselves, but also physicians, meaning GPs, but also patients, clinicians then later on in the clinic, so neurologists, to make an assessment of whether a patient is possibly at risk of developing dementia. Yeah? And this, as you can see here on the right-hand side, now really includes a bunch of different solutions, a bunch of different models, not only one model, but it's really a collection now of different approaches, data types, and models that is needed. So at home, for example, one thing that we want to support is simply online self-assessments. Yeah? So there also the question is, how do we identify there with appropriate models who is maybe in some sense abnormal in quotation marks? Yeah? So then eventually somebody may go to a GP, yeah? But then the question is what there, right? So what could be done at this stage? Yeah? Something simple, obviously, because a GP can usually not, as I said, do fancy brain imaging or what else. Yeah? But maybe there is something that a GP could do, and this then leads to this idea of using devices, yeah? Digital device technologies. And one of the things that we are testing at the moment is actually devices for sleep monitoring. So sleep is known in principle, or sleep impairments are in principle known to be a, let's say, prodromal signal of, but very unspecific, of course, of neurodegenerative diseases, specifically of Alzheimer's disease. And the question is, of course, now at this point, classically, sleep impairments are assessed by so-called sleep questionnaires, so structured interviews, if you want, yeah, so which assess, okay, so how well did you sleep during the last night or so on a certain scale, yeah, and of course, this is also nothing that a GP can do, right? So because they do not have the time for these questionnaires and they do not have them and they do not know them, right? And it's, of course, it's super subjective. Yeah? So because, I mean, who knows how well or bad you have slept precisely during the last night or the 2 nights before, what else, yeah? So therefore, indeed, the idea is, can we use simple consumer electronics, in fact. Yeah? So for example, such a smartwatch or Fitbit. Yeah? So these devices have an accelerometer, or in case of Fitbit, also a gyroscope. Yeah? And well, they produce data at first place, a lot of data, in fact. Yeah? And then there is one classical approach which you can take with these type of data. You can try to engineer certain features out of this data that's collected, for example, over the time span of a night. Yeah? And of course, then what you can do next is you can try to build machine learning classifiers that, for example, try to discriminate here between different diagnostic stages of Alzheimer's disease. Yeah? So, for example, mild cognitive impairments, meaning a prodromal phase versus healthy control, right? So how good is that possible with such a device? Yeah? And of course, if this is well possible, right? So then, of course, it would speak for the fact that you could potentially identify people already in a relatively early phase with such a device technology, right? And now, of course, the question that you have to always ask yourself here at this point is, well, I mean, of course, if I just knew how old a patient is and what his sex is or so, could I do equally well? Because this is an age-dependent disease, right? And therefore, naturally, always age is a possible predictor. So this is actually here these blue boxes here, yeah? Or lighter boxes here. And as you can see here, well, I mean, for example, here for mild cognitive impairment, here this discrimination with this classical feature engineering approach is possible to some extent here, yeah. And it's well at an equal level as here, where what you can do with if you had a structured questionnaire at hand here. Maybe if you have a larger study, so the gap might be a little bit larger, but qualitatively this is similar. Okay. But of course, what you can also do with this type of data now, you can exploit the facts. So that's actually time series data. Yeah. So in this here on the right-hand side just gives you an idea here. So how this raw data from the accelerometer actually of one of these devices here, the smartwatch, actually look like. And that actually allows you then with the sliding window technique, yeah, to train an LSTM, yeah, so a long short-term memory model on these type of data, yeah, as a classifier. And this actually helps, yeah, so because then of course you have suddenly much more data. Yeah, so you have now you exploit really the fact that from each patient now you have not only a certain set of features, but only one training sample, but due to this fact that you have a sliding window, now you have a huge number of data points. Yeah? And well, then you can also look what happens if I use only the actigraphy data, this is shown here in blue, or if I also include data from the light sensor, which may help additionally in some sense for at least for some of these differences. And you can see that in this case here, at least some of these classes here can be, or these diagnostic stages can then be better discriminated compared to this simple feature engineering approach. So what this actually, at the end of the day, I wanted to show you is here is indeed so that the type of data that we are dealing with here in this field are very different at first place. Yeah? So, and also the type of approaches that are accordingly necessary can differ quite drastically. Huh? Okay, so what I wanted to move on now next is examples here of what we do in the prognosis field. Yeah? So now we have talked about earlier diagnosis or approaches for AI-assisted earlier diagnosis, risk assessment. So now what can we do for prognosis? Well, I mean, if we talk about prognosis, at first place, we have to think or define what we mean by that. Yeah? In this field. So it's a bit different than in cancer, right? So where you would naturally think about overall survival and progression-free survival, right? So, I mean, one way to think about this is, of course, exactly what I said at the beginning. Yeah, it's a time to event. Yeah, so for example, first event of dementia diagnosis. Yeah, so then you're back to this risk model assessment. Yeah. And you would say, so at this point, of course, this prognosis would mean, okay, so at today, somebody is, for example, in mild cognitively impaired stage, right? So you look into certain data modalities and then you try to build such a time to event model. So this is one way of looking into it. But maybe a little bit more elaborate way is a so-called multi-state model. So you look into different disease stages. So where you also acknowledge the fact that there is, before people are mild cognitively impaired, they are cognitively unimpaired, of course, and there is also the possibility that people transit actually back from mild cognitively impairment to cognitive impairment. Yeah? And so this is and this can also be modeled, yeah, with according approaches, which I do not want to go over now here. So these are in essence generalizations, if you want, of time to event models. And last but not least, yeah, so one can also look simply into certain clinical outcome scores. Yeah, so for example, in the case of Alzheimer's disease, yeah, of course, the main aspect of interest or the outcome of interest is cognition. Yeah, so but what is cognition or cognitive performance? Yeah, so this can comprise various things, right? So it may comprise your orientation abilities, your language abilities, your memory, your calculation abilities, how you perform your daily activities of living. I don't know. Yeah, so it's extremely diverse. And accordingly, there's also not one particular measure for that, but there are various instruments, as we say, yeah. So basically, certain ways how to assess or test different dimensions of cognition being developed in neuropsychology. Yeah. So and here just examples of 3 of them, and as you can imagine. There is that obviously one way of looking into disease progression is simply to ask, so how do these scores now develop really quantitatively over time, point A? And would it actually be possible at first place to identify different, let's say, speeds of progression or yeah, improve increase here of slope of such a trajectory. So for example, can we identify clusters of people so that develop slower, yeah? So it show a lower slope here of such a cognitive impairment versus others that should demonstrate a faster slope. And can we do this not only in one dimension, but in several dimensions simultaneously? And this is in essence exactly what we tried to address with a modeling approach, which we developed a couple of years ago, so-called variational deep embedding with occurrence, called VADA. So where the idea is in essence that you have at the beginning a short indeed time series, because study data is usually not with hundreds of time points, but of course due to cost and practical reasons maybe you have 6, 7, 8 time points, but not more. So you have an LSTM encoder, right? So and then you have also an LSTM decoder. And well, then everything up to this point looks quite similar than a traditional recurrent variational autoencoder. But what is different here is that you do not only learn a single Gaussian here in the latent space, but you learn a Gaussian mixture model, really. So accordingly, also the elbow, so the evidence lower bound looks a bit different than in a traditional variational autoencoder. And what we did in addition here is to also acknowledge the fact that indeed study data has often missing values for practical reasons. So for example, people drop out of a study or people do not appear at doctor's appointments or such things. So which then manifest in these longitudinal study data as missing values. Yeah? So what do you do now with that? Yeah? So we in essence thought that, of course, traditionally what you can do is you can try to impute such data before you use any model. But of course, any imputation method is error prone, right? I can never be perfect. And of course, any error that you make during imputation will then propagate further to any further modeling that you make on these data. So this is a problem. So therefore, we thought maybe we can do this a bit more elegant and actually indirectly make the imputation part of the model training. So we have a so-called imputation layer in our neural network. So, and the idea here is shown below here. So in essence, there is a missingness mask here. So that is passed over to the model. And then, in essence, there's also a trainable parameter that is there for each and every entry that is missing. So where the missingness mask actually says, yeah, so this is a missing entry. Yeah. And now the thing is, and this is trainable, this weight. So this weight BIG here, which is introduced here for every missing entry, is actually trainable. So now this entire output of the imputation layer is, of course, passed forward to the rest of this VEDA architecture, and then, of course, also to the decoder. And then the thing is that in the decoder, of course, we try to reconstruct the observed data, right? So, and what we have to do now here is to also introduce the fact that indeed this missingness mask is there, right? So you only want to reconstruct, of course, the observed part of the data, right? And ignore the missing part. So therefore, we have here this term now appearing. And why is it actually now possible up to some extent to identify these BIJ parameters, right? So because we assume that the input features, of course, are somehow correlated, right? And of course, by the neural network are also used to, in the next step, then, for example, calculate the embedding, the clustering, and of course, also the decoding, right? So basically, every item or output that is in the reconstruction here considered, and therefore also, in some sense, implicitly uses information from this BIJ, right? And therefore, of course, I have the ability to learn these BIJ as well. So now we applied this VEDA approach here to indeed Alzheimer's disease here. So to first place ADNI, so a study that I introduced before, but then also later on to an external study called NACC. So it was actually trained on ADNI and then later on actually validated on NACC. So just tested there, not retrained. So this is of course possible since it's a generative approach. And the number of these clusters have been determined via the prediction strength methods by Tibshirani and Walter. And the interesting thing was now, so we found these two clusters, which these groups here, so these two clusters here are here shown here or depicted with their mean trajectories plus minus confidence intervals. So the interesting finding was that these clusters showed obviously here quite some differences indeed in the speed of progression, but no major differences in age at baseline. Yeah, so that means that these clusterings here cannot be driven simply by age differences. Yeah? There are also no significant differences in the hallmark biomarkers of Alzheimer's disease, APOE4 and A-beta, and no differences in A-beta plaques also at baseline. But in one of the studies, the NACC, a higher fraction actually of patients in the fast progressor cluster here, so this blue one here are APOE4 epsilon 4 variant carriers. So this is the risk variant for Alzheimer's disease, which actually perfectly makes sense here. So now, of course, the question is, what can you do now with such a clustering here? Yeah. So the question is, can we even predict whether somebody belongs to the fast or slower progressing fast cluster already at study baseline, right? And we developed a machine learning classifier for that here. So which in this case here, as best performing one turned out to be an XGBoost model here. And we did this in different versions here. So initially we used a multimodal classifier, or what is named here multimodal classifier, which used quite an extensive set of features here from ADNI, which however were not all available also in NACC. So if we restricted the features to those that were in common, so then this is here the so-called common classifier here, which actually doesn't perform so much worse here. And which showed, okay, so yeah, this is, let's say, okay-ish possible to predict. So already at baseline. Certainly too low for clinical routine. But what you may want to do with this is now to emulate something that is called an enrichment trial. So enrichment trial means the following. So you try to set a certain threshold of the classifier now. And then, of course, so the classifier produces a class probability, of course, for being class fast progressor. And what you can do now is you can see or observe what is the fraction now of fast progressing patients if I choose a certain threshold for this classifier, right? So if I'm very conservative with my classifier, of course, yeah. So then more or less everyone is at the end of the day only, so let's say I only take patients that at baseline predicted is probably 1 as fast progressors, yeah. So then this might be very few patients at the end, yeah. So, but those are, of course, then, yes, naturally all fast progressors, yeah. So this is the very right end, yeah. So on the other hand, if I choose a threshold of 0, so this is what I do traditionally, right? So there's no, I just take everyone, yeah? And accordingly, of course, there is a trade-off here, yeah? So if with the number of patients included in a potential study, yeah? So if I increase the threshold here, so then I have, of course, less patients to include, right? So fewer patients remain. And this is, of course, also as its problems, yeah, because if I want to do that, yeah, so if I here at the very right side, yeah, so that it would mean so that in the recruitment phase of a study, I would more or less reject everybody, yeah, so which is of course a big problem because then the study does never progress. Yeah? So in reality, I may want to choose something in between, let's say at 50% or what else, yeah. So this is actually what is further now investigated here is what effect this might have now on a potential sample size for a study. Yeah? So of course, then what I have to do in addition, I have not only to choose a threshold for a classifier, so let's say 50%, but I have to do a statistical sample size calculation. So I fix here the statistical power to 90%. And of course, there is an alpha of 0.05 as usual. And then I have also to suppose a certain effect size here, which in this case here was 27%. Yeah? So this is what has been observed as effect size in a recent experimental trial of an antibody. And then what you get here is this curve here on the left-hand side. Yeah? So you see the sample size reduction actually relative to a conventional study, which is the very left. Yeah? So basically, if I increase here my threshold, so then actually you can see here so that I have an optimum now achieved here of this curve here of more than 50% sample size reduction, yeah, at about 0.7. Yeah? So basically, if I would choose this particular threshold in my machine learning classifier, although it may not be good enough for really a clinical routine, I could still use it actually to select patients for a trial, yeah? Which would then be much slimmer and much have fewer patients involved compared to a conventional study. And that has very strong economic benefit, actually. So the traditional study here that we looked into costed 90 million. With an enrichment trial, we calculated that we would overall only need roughly 78 million due to the sample size reduction, which would actually come up with a cost saving of about 13%. Yeah? So that's quite significant. Okay, so now, of course, the thing is so that, I mean, making prognoses in this way is nice. Yeah? So, and as we can see, we have at least the possibility to choose such a classifier now for enrichment trials. Yeah? But I mean, the next thing that, of course, would be very nice to have, right? So is to say, I mean, can we not just predict something over time, really? So how does really the performance along one of these cognitive scores really develop over time? Well, I mean, given the fact that obviously there's so much variation in these scores, even from one within a daytime, even it could be so that your cognitive performance is better in the morning than in the evening or so, yeah. Probably a concrete or accurate prediction is impossible, but what might be possible is actually that you make a simulation of possible trajectories. So now this actually leads to the idea of building generative models that actually synthesize possible disease trajectories. Yeah? So now the question is, how can this be done in reality? So, well, and I will not go here to time restrictions now into too many details, but actually we came up here with a particular architecture for this type of questions. Yeah? So it's a generative modeling approach, which we call multimodal neuro-ODE. So it's a combination actually of a autoencoder-like structure, but but you also involve here a so-called neural ordinary differential equation. Yeah, so basically what the encoder learns at first place, the initial conditions of a differential equation system, which is itself parameterized on the right-hand side via a neural network. Yeah, so this is a so-called neural ODE. And this is a fully generative approach, and it's actually also continuous in time. Yeah? So therefore, you can, as you can see here, get trajectories that are very smooth over time. Yeah? And you can train such an architecture here, which we proposed here on these study data. You can use it then also for interpolation. For example, if there's a certain visit missing, you can try to interpolate it, or also up to some extent even to extrapolate. Yeah? So via these synthetically generated data then from these type of models. Of course, the question is then with these synthetic data always how good or bad this is, right? So there are different considerations for that, right? So one can compare distributions against real data, one can compare correlation matrices, one can look into classifiers that try to discriminate between real and synthetically generated patients, various approaches that I will not go over now. But in essence, at the end of the day, the utility of all of that is several-fold. So on one hand, as said, yeah, so there could be the possibility to simulate possible disease trajectories for an individual patient. Yeah? So and specifically in this context, also simulate possible scenarios, yes, that may not even have been observed in reality, such as, for example, stop of smoking, reducing of weight, or taking this or that medication. And on the other hand, of course, also for the design of trials, this could be of interest. Yeah? So, for example, as I said, so interpolation between visits, yeah? So which could help to time the visits in a real trial. So sharing also of synthetic control arms between emulations, and also really emulation of entire trials, and of course also for educational purposes. So this is something that we are also now exploring in larger extent here now in the context of a new project called Cynthia here. So again, so this is a big project here, which is half funded by industry here in the Innovative Health Initiative. So there's more or less the entire who is who of pharma industry represented in this project. And the aims are really to get a better, thorough understanding of the requirements for synthetic data generation in a set of relevant healthcare use cases, established according generation methods and tools, and of course also evaluation methods specifically regarding then also the quality of synthetic data, but also utility in various healthcare applications. And this utility evaluations then also include, for example, here synthetic control arms for clinical trials, and include, by the way, here, as you can see here, different disease modalities such as different cancer types, Alzheimer's, and type 2 diabetes. So now if you put all of this together, right, so you can see so that there are different, on one hand, approaches that help us maybe to diagnose something, right? So with machine learning, to prognose something, right? So, but also to simulate something, right? So maybe, or even counterfactually with generative approaches. And if you combine all of these methods together, so then in essence you end up as a concept, so that's now propagated also by the European Union, which is called a digital, or they call it virtual twin. Yeah? And actually there's quite a number of papers around this now also. Yeah? But really, one of the ideas of such a digital or virtual twin is that you have initially really all multi-scale, multimodal disease data of a given patient, right? And that's really along a time frame of a patient you apply and continuously update diagnostic models, prognostic models, and you accompany this really with a simulation of possible disease trajectories at this given time point. And once the data is then there, then, as I said, so you would go back and you would update the model, etc., etc., etc. So this is largely a vision. Yeah? So it's not yet reality, but it's something that's at the moment widely discussed and propagated. Yeah? And therefore, I wanted to share this with you. And we have actually also the luck to be part of one project that actually tries to implement such an approach here. In fact, not in neurology, but in cancer. So specifically here, looking into multiple myeloma. I will not go into detail here due to lack of time here, but you will hear probably more about this during the next year. So the project has just started. And I also want to advertise a bit here. So since Daniel, you began your talk, your part here with an advertisement, I want to do the same here. So we actually have also now a graduate school, in fact, here. So it's a Marie Sklodowska-Curie doctoral network, actually funding 14 PhD students here. And I'm very happy to be the speaker of this network here. Actually, the co-speaker is somebody from industry here also. And you can see also this quite covering a number of different countries here in Europe. And in this program, we will actually do similar things as what you advertised here, Daniel. Yeah, so and in the research field, our aim is really to try to address, specifically, by the way, with focus on neurology and Parkinson's disease, more specifically, different questions in precision medicine, in digital health, but also regarding trustworthiness of AI models, so which is, of course, now a topic that is increasingly receiving attention. And I think here I stop, and I want to acknowledge the people from my team here who contributed to this work, specifically also the alumni here listed on the right-hand side here, so which have done great, fantastic work here and helped to generate the results here so that I showed, and of course all the funding bodies that give the money for the research that we are doing, and you for your attention. And I am looking forward to receiving any questions.